Well, my experience, it was definitely a challenge.
Basically, it was just simple rash because of the sun. But I told the doctor, I say I'm a gay man and I'm starting having, intercourse, and he immediately say, "Oh my God, I think you have HIV."
I just felt like I wasn't being listened to, as far as me being able to report what was going on.
I struggled like for 2 weeks waiting for my HIV test result, thinking I'm HIV positive and how everything will run.
I was pretty much given a folder of of providers and told that I couldn't go to the Army.
The test came back negative, and he said, "Oh, you're lucky. You are being risky behavior, so you're lucky. You don't get it this time, but be careful because you're gonna get it."
That really changed my perception of how individuals are treated.
It does impact my life. I say, "Oh my God, this is horrible."
Whether it's the treatment of an established HIV diagnosis or just making sure that when individuals are coming in or young people are coming in to be tested, that the quality of care is an empowering experience that will allow young people to continue to be served in their community.
Issues in terms of barriers to getting younger patients, adolescents engaged and staying in care, actually, I think is actually on two fronts. One, if you talk about the provider side, the providers aren't capable in terms of understanding adolescents in general. Most of us are adult providers, so we're used to talking to patients as adults. And so a lot of times that doesn't translate well to adolescents and younger patients.
I think the pieces that are really difficult for these kids is finding someone that actually is comfortable with talking about sexuality. And I don't know that we do a great job in the United States in medical schools really developing curriculums for the LGBT patients.
The issue with younger patients is that they don't understand how to navigate, and you're again taking a child and putting them into an adult situation, and they don't know how to navigate, and they're used to having someone else speak on their behalf, and now you have to kind of get to coach them into advocating for themselves.
The needs of the transgender population, the transgender youth, are even bigger and probably more accentuated than any other LGBT subgroup.
A lot of times there's underlying homelessness that has to be addressed, histories of substance abuse, and those things all impact their physical health. So I think for us as healthcare providers, we need to be able to address the physical as well as those social needs that they come in with.
Very often, these young individuals have been subjected to things like domestic violence, emotional, psychological, and physical abuse. It creates a big demand for mental health services that are not, again, frequently, providing or available in adult healthcare settings.
I think the other piece of it is workforce. I don't think we have a sufficient enough workforce of providers, healthcare providers, really wanting to work with these groups. And we really do need to look at this critically. The HIV workforce in terms of providers is dwindling. And if we're going to think about where this will be absorbed, it's going to be with primary care, whether it's peds or adult medicine, internal medicine. And are our primary care providers really ready for this?
As the rates of HIV continue to rise among young people, particularly among young men who have sex with men and transgender youth, we are going to see an entire population being catapulted into adult health care. And we've got a whole system of care providers who are not prepared to receive them. So the National Alliance of State and Territorial AIDS Directors decided to develop an issue brief and this resulting podcast that really focuses on the practical steps that health care providers can take within the clinical setting, within community-based settings, to engage young LGBTQ youth in care and then keep them in that care over the long term.
In order to commit to provide healthcare services for adolescents within an adult environment, I think it's important to make sure that key issues are addressed, among which I think one of the most important ones is actually the mental health services, having available mental health services.
And I think providers who are working in these clinics need to be aware of it and advocate for it within their own institutions. That's the only way that we're going to make a difference for our patients.
In building that relationship with young MSM of color in a healthcare situation, the biggest thing is just, remove all judgments when you walk in the door and just be very calm and just talk to them on their level.
It has to do with developing a trusting relationship with the individual. Second, that they feel that you care for them. I think third is the issue of confidentiality. They need to feel that they can trust you.
I don't wear a white coat. I don't wear a tie. When I'm talking to my patients, they're sitting in the chair, I'm sitting in the chair, we're at eye level. There's none of the paternalistic type things that you see in medicine.
And if you're using big terms, like long words, explaining to them what it is, because a lot of times young people, especially young people that I've seen and worked with, where you come from a family where education is not important, like where you're always on the streets, hustling or doing what you're doing, when you go into a medical setting, you get really intimidated by the language, the way people act towards you.
Who's the first person that you see? Is the cleric, is the receptionist. So it starts there.
There's a very mixed bag of staff from age range to early 20s to however old, and these people have just been trained and really well equipped to deal with the youth.
And treat everyone in the same manner, regardless of their gender, their sexual orientation, and the way they express, both their gender and the sexual orientation.
There's a lot of education that needs to be done, not only on the patient level, but also on the provider level, for sure. And it has to start at medical school.
I would talk about the house ball scene. I would talk about transactional sex work. I would talk about risky sexual behavior, PrEP and condom usage and risk compensation, substance use, I think, is a really big thing that gets overlooked.
So when you would talk about infectious diseases, that there would be a lot of conversation around how to take a good sexual history, how to feel comfortable with the patient talking about whether or not they have vaginal sex, oral sex, anal sex, and exploring that with that patient. That's the only way you're going to know whether or not you need to do pap smears or anal smears, and how you can keep a patient healthy.
I want to talk about the transgender community, which is an emerging community, which is one of our most highest risk populations. So I think they don't get enough attention.
I also want to know about home. What's home like? Is it safe for me to write you this prescription? And whose insurance are you on? Are your parents gonna receive EOB, which is an explanation of benefits that insurance companies send out, and whether or not that might be a problem for you. So I want to make sure that you're also safe.
There's a stigma to being gay. There's a stigma to being HIV infected. There's a stigma to certainly even to be seen getting tested for HIV, that represent important barriers to access to this kind of counseling-intensive services.
Just incorporate their STD HIV screening needs into their normal healthcare settings, so that they don't have to go to that extra space that everybody knows if you cut down this hallway, you're going to the STD clinic.
I think the one thing we don't do enough of in medicine is really sit with our patients in our communities and let them teach us. We do a lot of assumptions, and I think the one thing that community-based participatory research has shown me is you're sitting with your patient, with your community, and they're telling you exactly what they need.
You could volunteer just an hour, 1 hour a week, 1 hour a month in those places where you have this contact to the community is where you're going to learn.
All of my work, qualitative work with the kids, really showed me that empowering the kids and also showing them, actually demonstrating, using the multimedia tools that we now have to allow them to see really healthy conversations around sexuality and condom use and prevention. All of these things are really important to them. And they want to know. They're very smart and they want to take ownership. So I think it's up to us now to be able to give that to them.
HIV is on the rise in the United States. And if we don't engage these young people in their care, we risk jeopardizing all of the prevention efforts that we have implemented so strongly to date, and contributing towards an increasing disease burden and an increasing economic burden on our healthcare system.